Hi, everyone. My name's Megan Rafferty. This is Eli Walsh, and we'll be going over constipation with you guys today.
So first, what is constipation? Constipation is a common GI symptom that affects about 14% of the population, and it's defined as infrequent evacuation of stool accompanied by straining with hard feces and a feeling of incomplete evacuation of the rectum, and it can happen with or without abdominal pain. The reason that stool gets hard is because water is often reabsorbed from the stool if it is not immediately evacuated. There are several factors that can increase your risk of constipation, such as diet, lifestyle, medication, and other disease states that the patient has. Constipation can be defined in several different categories. It can be secondary to a disease state or medication. It can be acute or it can be chronic, and then it can also be induced by opioids. Those are in its own little category there. If left untreated, it can cause a lot more serious issues, such as ulceration, perforation, increases your risk of cancer, and several others listed. There are several non-medicinal methods of prevention and treatment of constipation that revolve around dietary and lifestyle changes. So for dietary changes, the most important thing that you can do is increase your fiber intake. It's recommended that you increase your fiber to 25 to 35 grams a day, or roughly about 14 grams per 1,000 calories eaten. Listed, we have some very high fiber foods. It's also important to increase your fluid intake. It's recommended that you get at least 2.5 liters of water a day. That's going to help that stool from drying out and getting hard. Other lifestyle changes, routine exercise can help increase peristalsis and help move that stool through the GI tract. And lastly, avoid ignoring the urge to defecate, as that can help, or that can prevent the water from being absorbed out of the stool and making it harder. There are several over-the-counter products we'll get into in this discussion. In our goals of therapy, we want to promote comfortable defecation by increasing water content and increasing motility of the intestines. That's the bottom line of how all of these over-the-counter drugs work. We want to use the lowest effective dose for the least amount of time, as we do with every medication. Our first line is typically going to be bulk forming and surfactant laxatives. Second line is going to be osmotic and saline. And third line are going to be stimulant and lubricant, and you can also use some saline there as well.
Okay, so I'm going to walk us through all of these agents now. We'll start with bulk forming laxatives. These are a very commonly used laxative. Examples would be Metamucil Cilium, frequently used, come in a lot of dosage forms. Mechanism of action for these, they bind fecal contents and pull water into the stool, softening, lubricating the stool, easing its passage. This increased water increases its bulk, stimulating peristalsis. Some adverse effects, but generally well tolerated. Just some abdominal fullness, maybe nausea, vomiting with excessive use. Contraindications to these laxatives would be acute surgical abdomen, strictures of the esophagus, GI ulceration, stenosis. And then we want to be cautious of gluten intolerance and celiac disease because wheat dextrin contains wheat gluten. A handful of drug-drug interactions, quinolone, tetracyclines, anti-diabetic agents, carbamazepine, lithium, plasma levels can be decreased. And then licorice as a food interaction is an interaction with most of our laxatives, and it increases the risk of hypokalemia. These bulk forming laxatives are our preferred agent. They are not systemically absorbed. They are safe to use in pregnancy. They are not really used with opioid-induced constipation. We want to make sure that we're taking enough fluid, and this is general rule for all of our laxatives, is that we want to make sure we're taking them with at least 8 ounces of fluid. And then with peds for these, we just want to consult a pediatrician if you're less than 12 years old. Moving on to our surfactants, big example would be docusate sodium or cholase. Lots of dosage forms. These reduce surface tension of liquid contents of the bowel, promoting liquid into the stool, forming the softer mass. A lot of times we use these with fiber just because the data is a little limited of these on their own. Very few adverse effects with these. Drug-drug interaction with mineral oil, which is another laxative we'll talk about later. This is the laxative of choice for patients who should not strain during defecation. We want to remember that these also only prevent constipation. They do not treat it. Special populations, this is pregnancy category A, so it is safe to use. However, infant risk cannot be ruled out. So use in infants, we want to make sure we're keeping an eye on. Osmotic and hyperosmotic laxatives, big examples would be our polyethylene glycol or Miralax, and then lactulose is within this category. It's just a prescription only medication. These metabolize into solutes in the GI tract, increasing osmotic pressure, drawing fluid into our GI tract. And then this in turn stimulates intestinal motility. Some adverse effects, not many, some rectal irritation, but that really goes for all suppositories. Considerations, glycerin is our safest laxative. We use it in infants a lot. We do want to be cautious with elderly and just general dehydration, risk of volume depletion. Sorbitol and lactulose can increase glucose. And then we want to be cautious just administering medications, the timeliness of other medications. We also want to be cautious with magnesium and renal failure. So those two are two other laxatives because we're increasing our risk for hypermagnesemia. Stimulant laxatives, big one is Senna and then also Dulcolax. These increase peristalsis through direct effects on the smooth muscle of our intestines and then also promote fluid accumulation. Bigger adverse effects with this group. These can cause laxative dependence. They can cause ischemic colon. They can cause cathartic colon, and then also electrolyte imbalances. Oops, sorry. Contraindications, we don't want to use bisacodyl with appendicitis, intestinal obstruction, gastroenteritis. We want to avoid long-term use to avoid laxative dependence, and then also the irritating effect on our musculature and mucosa that this can cause. Castor oil, we want to avoid in pregnancy. It can stimulate uterine contractions. And then in general, this class is not as well tolerated. A couple drug-drug interactions that we just want to be aware of. And then Senna with digoxin can increase your risk for digoxin toxicity. Lubricant laxatives, briefly mentioned mineral oil earlier. It coats and softens the stool, preventing reabsorption of water from the stool. Typically, we give these as enemas. They are available in liquid. Big main adverse effects would be oily rectal seepage from our enemas. It can cause lipid pneumonia in peds and the elderly. Some contraindications as well. Big drug-drug interactions would be with our surfactants, just because they increase mineral oil absorption, increasing our risk of these adverse effects and liver toxicity. Warfarin also increases due to the impaired absorption of vitamin K. Lubricant laxatives impairs absorption of our fat-soluble vitamins, so A, D, E, and K. We do want to be cautious with Beer's criteria. Fetal risk is not ruled out. And then, however, these are also effective at preventing straining in our high-risk patients. Moving on to saline laxatives, we also use these a lot. Fleet enemas, milk of magnesia. They're similar to hyperosmotic laxatives that draw water into the intestine through osmosis, creating increased pressure, resulting in increased peristalsis. Typical adverse effects, they do have some alterations in electrolyte imbalance. General contraindications come with sodium phosphate enemas and then magnesium hydroxide and magnesium sulfate. Drug-drug interactions with this category, medications that require acidic environments to be absorbed, as these can alter the pH, tetracycline and quinolone antibiotics, and then medications that affect the kidneys as well due to these electrolyte imbalances.
I was muted. Moving on to complementary and alternative medicine, or CAM products. The first example that we have for you is ginger. This one's been around for a long time, dates back to early days in Chinese medicine. It stimulates digestion, absorption, and relieves constipation by increasing the muscular activity of the GI tract. Comes in a lot of different dosage forms, whether it's capsules, extracts, oils, and it can also be used to brew tea. Some adverse effects, it's going to cause heartburn, diarrhea, and mouth irritation if used excessively. Dosing considerations, don't take more than 4 grams of ginger daily or 1 gram if you are pregnant. And talk to your doctor before taking this supplement if you have gallstones, hypertension, or diabetes or bleeding disorders. Some drug-to-drug interactions, it can increase your risk of bleeding if used concurrently with warfarin, clopidogrel, or aspirin. It can increase your risk of hypoglycemia if taken along with anti-diabetic medications, and it can increase your risk of hypotension if taken with other antihypertensives. It also increases the absorption of cyclosporin and metronidazole, and it can inhibit CYP2C19 and CYP3A4. Another example that we have of a CAM product is probiotics. These regulate the fecal microbiota and increase levels of organic acid to promote intestinal peristalsis, shorten the colon operation time, and lessen symptoms of constipation. These can cause upset stomach, diarrhea, flatulence, and bloating, and we do not want to give these to immunocompromised patients without consulting a specialist first. It comes in a lot of different forms. It can be found in foods and drinks, and that can also be taken in capsules, powders, or oral suspension. And it can also affect antibiotics and antifungal properties because it is impacting the gut microbiome. If the over-the-counters are not working, there are several prescription options. The first group being secretagogues, chloride channel activators, and guanylate cyclase C agonists. These essentially increase the excretion of or the secretion of chloride-rich fluid, which increases fecal transit. We give these to adults with chronic idiopathic, opioid-induced, or IBS-induced constipation. Don't give these to patients if they have mechanical obstruction or severe diarrhea, and they can cause nausea, vomiting, and diarrhea as well. Your other option is going to be the peripherally acting mu-opioid receptor antagonists. A couple examples are listed. These block opioid receptors found exclusively in the GI tract and the periphery, which decreases the opioid-associated constipation without compromising analgesic effects in the central nervous system. These are only given for opioid-induced constipation. Contraindications are going to be a concurrent use with a strong CYP3A4 inhibitor and mechanical obstruction. These can also cause diarrhea, nausea, vomiting, headache, and flatulence. A couple surgical or anesthetic concerns with the over-the-counter or CAM products. Ginger, as we said earlier, can increase your risk of bleeding. So we recommend the patients stop taking ginger supplements 5 days prior to surgery. And if they do take that prior to surgery, inform the surgeon and understand the increased risk of bleeding. Lastly, normal or abnormal use of laxatives can cause electrolyte imbalances. Ensure that the patient is taking these appropriately, and if there's any suspect that they are not, or they've been taking it for a long time, just check a pre-op EKG to ensure that there are no hypokalemic cardiac changes.
Yay.
There are
Thanks for
references.
listening.
There was a typo in the presentation. Ginger actually decreases the absorption of cyclosporin and metronidazole, not increases. We just wanted to correct that.